Welcome everybody. Got it. Okay. Welcome everybody to this exciting event and webinar. It's fabulous to have so many members of our community here to join us. We have a fabulous presentation coming up. However, before we jump into that, I would like to start by acknowledging the Wurundjeri people of the Kulin Nation, the custodians of the unceded lands from which I'm zooming in from. I also invite you to reflect and acknowledge country from where you may be joining us. And as we meet in this physically dispersed and virtually constructed environment, it's important to recognise the long-standing tradition of learning and transmitting knowledge amongst communities that has been occurring on these lands for thousands of years. And just a few housekeeping things before I hand over to Fiona. So we invite participants to share any questions that you may have in the Q&A function. And just a note that this is distinct from the regular chat. And if you see a question there in the Q&A that you particularly like, you can give that question a thumbs up, and this will assist our lovely moderator, Torlene Edgerton, to understand which questions are of most interest. Additionally, this webinar will be recorded and available afterwards on the CHESM website. Okay, now it gives me great pleasure to hand over to our Head of Department, Associate Professor Fiona Dobson, to introduce our speaker tonight, Rana.
Thanks very much, Jess. So this year, the Department of Physiotherapy is celebrating 30 years of physiotherapy graduates. And from its beginning in 1991 with the Bachelor of Physiotherapy and then the Doctor of Physiotherapy from 2011, the department is distinguished by its commitment to fostering research and innovation, professional development, community engagement, education and training. And it serves as a central hub aimed at improving health outcomes and advancing physiotherapy practice. As part of our celebration of 30 years of physiotherapy here at the university, I'm welcoming Professor Rana Hinman, physiotherapist and Deputy Director of the Centre for Health, Exercise and Sports Medicine at the University of Melbourne. And she's going to discuss the findings of her recently published Lancet article, a non-inferiority randomised controlled trial, which compared physiotherapy delivered via video conferencing to in-person care for people with knee osteoarthritis. Now, Rana began her career as a physiotherapist studying the Bachelor of Physio here at Melbourne, going on to work clinically at the Royal Melbourne Hospital and into private practice. And then she returned back to the fold at university to complete her PhD. She is a stellar researcher physiotherapist and a National Health and Medical Research Council Investigator Fellow here in our department. And her research focuses on clinical trials of non-drug, non-surgical treatment strategies for osteoarthritis, in particular exercise rehabilitation and biomechanical interventions. And her research really aims to develop and evaluate strategies to support positive behaviour change in people with chronic musculoskeletal conditions, particularly adherence to exercise. She has a strong focus on implementation science and is interested in developing and implementing methods to increase access to care, including telerehabilitation and other digital health strategies. So I am very much looking forward to hearing from Rana as she takes us through the findings from her Lancet article. And I'm sure she will share some hot tips on how to get published in such a high impact journal. Welcome everybody, enjoy, and now over to Rana.
Thanks very much, Fiona, for that really lovely introduction. And thanks very much also for the invitation to speak tonight. Certainly, I think a really, really relevant topic to really speak to as we reflect on sort of 30 years of physiotherapy. Now, I'm just going to minimise everybody there. And as Fiona said, I'm going to be talking about our recently published PEAK non-inferiority RCT, which really was focused on physiotherapy video consultations for managing knee osteoarthritis. The paper was recently published, and I direct you to the paper because obviously we've got a limited time together tonight in this webinar. And whilst I will be focusing on the clinical trial first, there was a number of studies that branched off from the PEAK study that are related and really help sort of unpack and explain some of the findings that we found, and also to think about what these research findings mean going forward for clinical practice. So there's a more than one paper I'll be talking about, and I won't be able to go into all of the details, so I direct you to this paper if you're interested in more detail. But if we think about the global need for rehabilitation, and it really is huge. This is data that came from the Global Burden of Disease study in back in, I think it was 2019 data. It's based on, basically at that time, it was estimated that 2.4 billion people around the world have got a health condition that will require rehabilitation at some point. And if we think about the health conditions that drive the need for rehabilitation, musculoskeletal conditions, including osteoarthritis, are the greatest driver of this need. And this is just data from that Global Burden of Disease study, as I said, showing the number of people at that time point who had a health condition that could benefit from rehab. And you can see there that musculoskeletal disorders make up about 2/3 of those people with health conditions. And I've just highlighted that there with the red arrows and the dark green colour. So really showing the need for rehab for musculoskeletal problems. What we do know, though, is that attending in-person allied healthcare for rehabilitation can be difficult for lots of people, in particular those who are geographically isolated from attending a healthcare professional in person, or for people who might live just around the corner from a healthcare provider, but have real problems attending in person due to pain, physical disability from their condition. Maybe they're time poor, can't fit the increasing travel times, parking difficulties that come with getting physically to a location to see a health professional. And, we're here in Australia, and it really, I always like this image because it really does show the vastness of our country and the real geographical spread that we have, that we face in providing healthcare. And certainly if we think about the Australian physiotherapy context, our workforce data from registered physiotherapists in Australia shows that 81% of the physio workforce is located in metropolitan areas, which really are clustered around, the coast of Australia. We also find that most of our physiotherapists are in the private sector. And if we look at the number of physios per head of population, if you like, we can really start to see that disparity in where the workforce is located, where we see 120 full-time equivalent physios per 100,000 people in metropolitan areas, down to as few as 30 full-time equivalent for the same number of population in small rural towns. And this isn't a problem that's just confined to Australia. And in fact, we've probably got quite we're probably what's the word I'm looking for? We're very well served by the numbers of physiotherapists in Australia. Globally, this is data from the World Physiotherapy Census that was conducted in 2022. And what we really see is that physiotherapists on average really vary across the world. And in certain segments of the globe, if you look there at Asia, Western Pacific and Africa in particular, the number of physiotherapists per head of people is really much fewer than other locations. So that really does then also speak to that geographical dispersion, if you like, also with how far people will be located around potentially their nearest physiotherapist. And so that we know that telerehabilitation or telehealth, the terms can be used interchangeably, can really increase the reach of rehabilitation and physio services. But there is a lot of uncertainty about its clinical effectiveness, its cost effectiveness, its quality, and its safety. And there has been a couple of systematic reviews and meta-analysis conducted, if we're thinking specifically in musculoskeletal problems, because that's where I've presented that data showing where the greatest need is. The most recent systematic review and meta-analysis, which was only published last year, identified only 4 RCTs in total, with a total of 352 participants that compared video consultations head-to-head with in-person physiotherapy. And the quality of that evidence was considered very low quality evidence, so with very high uncertainty, even though the findings suggested there might be no difference between video and in-person care. The other thing to note that those 4 RCTs were very much focused in people pre and post joint replacement surgery. So at that very surgical end of the spectrum of musculoskeletal care. And so there's real gaps in our knowledge, and in particular, no non-inferiority trials looking at non-surgical rehab of any musculoskeletal condition, including osteoarthritis. And it's really important that we think about what the implications of this lack of evidence might be, particularly given that, you know, the history of tele-rehab or telehealth is pretty new. This is a little timeline sort of talking about showing when telehealth really originated and really when it's certainly started to be first reported and used in Australia. We can see that the APA published their first position statement on tele-rehab in 2009. And really the first RCT was published by Trevor Russell up at UQ in 2011. That's about the time when the National Broadband Network first went live. And so what we have found is that the lack of one of the drivers for why tele-rehab services have been so poorly uptaken and implemented is because there is a lack of evidence. And certainly, you know, we're here talking about 30 years of physio at Melbourne Uni. As Fiona said, I graduated from University of Melbourne in 1995 in the second cohort of graduates. And certainly when I went to uni, either in the curriculum that I was taught on campus or in my clinical placements, there was no mention of telehealth or telerehabilitation. And so it's probably not surprising that when we look at data that was collected pre-pandemic in 2016, only 6% of registered physios in Australia were actually delivering care via tele-rehab. And then, of course, we know that the COVID pandemic came along and we've seen a real explosion in telehealth services and some real benefits that came from that, which is now what we're seeing with some permanent funding now of telehealth services, which is really changing the landscape. But the lack of evidence is really a big factor in driving uncertainty around, well, who are these services for? Do they work? It's also driving consumer perceptions. And if we think about osteoarthritis, it really is a really nice model for telehealth. It's a high burden chronic condition that results in high patient burden, leading to problems of chronic pain and physical disability. And importantly, high quality evidence-based care for the condition is focused on self-management, on education, exercise and physical activity, rather than hands-on approaches or pharmacological management. So lifestyle management, so to speak, is really the mainstay of care for OA, which really lends itself nicely to a telehealth model of care. So with the PEAK RCT, our primary aim was to determine if video conferencing is non-inferior to in-person consults with a physio for improving knee pain and physical function at 3 months in people with knee OA. We also had aims related to our secondary longer-term follow-up time point of 9 months, and we also had a range of secondary outcome measures. It's probably important to note that our aim was around determining non-inferiority. And this, you know, really the idea for this trial came to me from when we were in discussions talking with a private health insurer. And I remember clearly this day talking with Medibank, and they were saying, we were talking about the potential scope of telehealth. And they went, but yeah, is it effective and isn't it worse? Or how does it compare to face-to-face? And so that's what a non-inferiority trial is really about. It's working out or testing, is video conferencing not unacceptably, not worse than in-person consults. And I don't use the word similar because there's another trial design, which is an equivalence trial design, which is different. So what we're really looking at here is is it not worse than in-person consults? And so the methods that we used here, and I'll point you to the study protocol if you want a lot more information because we published that, but it was a 2-arm non-inferiority RCT. Our participants were also the assessors in this trial because the vast majority of our outcomes were patient reported, and they were unblinded to their group, but they were blinded by a process of limited disclosure, and I'm going to talk about that in a moment. We recruited 394 people from the community, directly from the community in regional and metropolitan Victoria, Queensland and New South Wales. And people had to be adults aged 45 years and over, meeting clinical criteria for knee OA, and with a sort of a minimum level of pain and physical disability that would sort of be reflective of what might drive someone to go and seek care in the first place. So as I said, we used limited disclosure to blind people to the alternative or the comparator arm in the trial. In a comparative effectiveness trial, such as what a non-inferiority trial is, it's comparing a new intervention, in this case, telehealth, to the gold standard, in this case, in-person care, and really seeing, well, how does it stack up? Is it not worse? And so you can't blind people because they're getting 2 active treatments. We were quite concerned in this trial that because consumers have really strong preconceived ideas about what physio is and that it's a hands-on in-person intervention, that if we had people unblinded and they knew what the 2 comparisons were, that we'd probably be self-selecting people who wanted to be in the in-person treatment arm and would probably bias results towards that. So really to keep it a fair playing field, it was really important that we use limited disclosure. And so what we did when we recruited participants to this trial, they signed up knowing that they were coming into a trial that was comparing the effectiveness of 2 different physiotherapy models of service for OA that would involve consultations with a physio for exercise and education, but we didn't tell them what those models of service would be. And in fact, we told them that physio care can be delivered in a whole different ways of settings and formats. And we put lots of examples in the plain language statement: face-to-face, telephone, video conferencing, individual versus group classes. The setting could differ, whether it's a home visit, a private practice, and we didn't tell them what the comparisons would be. So they signed up knowing that they would just be getting physiotherapy care, but they didn't know that it would either be telehealth or in-person. The interventions were the same in both treatment arms. So people got 5 one-on-one physio consults over 3 months. And the basis of the treatment in those consults was patient education. It was an individualised strengthening exercise program to be performed at home, an individualised physical activity plan with goals, and a wearable activity tracker to help people meet those step goals and physical activity plans. And along with the activity tracker, we gave patients exercise bands so that they could do their strength exercises at home, and a range of information booklets to support their consults. And irrespective of whether they were in the in-person arm or the telehealth arm, this is what the package of care involved. So the only difference between the 2 groups was how the physio and the patient consulted. So in the video consult arm, the consultations occurred via Zoom, and for the in-person care arm, the patient attended the physiotherapist's clinic. And this just shows you the range of materials that we sent out to the patients once they were enrolled in the study, ahead of their consultations, with their TheraBands and their booklets and their wearable activity monitor. We recruited 15 physios across 27 clinics in Metro and Regional Victoria and Queensland, and trained them to deliver the treatments in this trial. 60% of them had no telehealth experience before. So we had to train physios we gave them some upskilling in knowledge about osteoarthritis and best practice management, and training in the actual treatment elements of the PEAK program. But we also had to train people in how to use Zoom, because this trial started pre-COVID and most people, as I said, were not using telehealth. And so we did our training formed what you see here in this diagram. So we did some e-learning modules to deliver the sort of core content in knowledge around OA and the components, and around how to use Zoom and troubleshooting, for example. Then people, once they'd completed those, did some practice. They did a mock video consultation with one of our researchers acting as a patient. And then after that, they did a few pilot patients so they could practice their skills via Zoom. We were less concerned about people being able to deliver the intervention in person. It was more about making sure that they were actually capable and able to use Zoom. And after that, then the trial commenced, and physios were able to start seeing patients in the trial. We had a whole raft of outcomes. Our primary outcomes were pain and function, as I said, but we had a whole range of secondary outcomes that we also measured, including quality of life and self-efficacy. We were interested in the travel distance and time that people were using to get to and from appointments, attendance and adherence, adverse events because of concerns that people hold around safety of telehealth, satisfaction because of concerns people have that it's just not as good, cost effectiveness, and we looked at fidelity to the trial. And for those of you who might be interested in the sample size calculations, we had 394 people were needed. And in a non-inferiority trial like this, the non-inferiority margin is really important to pre-specify, because that's how you analyse your findings. And you'll see that once I get to the results slides, but we set that threshold as being 0.95 units of the 0 to 10 NRS function, pain scale, sorry, and 5.44 units as a function on WOMAC. And that's because those are lower than what's considered a clinically meaningful difference between groups, but also reflects certainly the function measure there is certainly the kind of measure that's also reflective of what's used in similar drug trials for non-inferiority designs as well. This is just a busy slide showing you the trial flow. We recruited people between December 2019 and 2022, and so you will notice that this was our trial kicked off just before COVID, and I'll talk to that in a moment. Probably the key message from this busy flow chart is always looking at retention. And due to the really amazing work of our trial coordinator, Penny Campbell, for this trial, we had really excellent outcomes in completion outcomes, where you see 97% of our participants completed the primary outcomes at 3 months and 94% at 9 months. So that was really excellent data to have there. So we kicked off the trial, and then COVID came, which was, caused trouble for everyone, everywhere, clinics, researchers alike. This was a challenging trial because, unlike a lot of other clinical trials that were generally delivering care in person and could switch to offering or continuing their trial by delivering care via telehealth, we couldn't do that in this trial, because if we shifted everyone in the in-person arm into video conferencing, we would no longer have a non-inferiority trial, and we'd no longer have our 2 treatment arms. So we really had no choice but to suck it up and stop recruiting and follow and just wait things out. So we did have to halt recruitment numerous times across the couple of years, more so in Metro Melbourne because of all of our lockdowns. One of the benefits of the trial was that we were recruiting regionally, and we were recruiting in Queensland. So apart from the very first lockdown we had in Australia in 2020, when we had to stop recruitment across all sites, even for the rest of the trial, even when we had to stop recruiting in Metro Melbourne, which was quite often, we were usually able to continue recruiting in Queensland because they weren't in lockdown, or often even in regional Victoria. So usually the trial didn't grind to a halt, but it would slow down. We did have to suspend in-person consults for a period of time in 2020 due to lockdown. So that really affected the in-person arm. What we did for when we were able to resume in-person consults was for people who were still within their 3-month intervention window, We shortened the period of time between their consultations. So we tried to get as many of their 5 consultations in as possible. And by the time Melbourne's second big, our long lockdown in 2021, and maybe lockdown 3 and 4, I've lost count, were occurring, by that point, clinical trials were allowed to continue. So we were allowed to continue with our in-person interventions for those later lockdowns of the pandemic. Primary outcomes. What I've put up here, this is just to sort of show, this is the pain on walking data, just showing you the mean scores across time in both arms, showing the within group change. Both groups reported clinically meaningful mean improvements in pain and function. I think it's pretty much identical that you can see here in pain on walking over time, and also there with physical function as well. I put these graphs up because I think visually it shows you the magnitude of improvement that we see in both arms. I don't want to overemphasize them because they're the within group changes. And of course, in a clinical trial, we draw our conclusions on the between group differences, and a non-inferiority trial is no different. And so this is the key analysis that allows us to draw our conclusions. And as I mentioned a few slides ago, we have to draw those conclusions based on the non-inferiority margin, which is the dotted line that you see in each of these panels. So the top panel is presenting the pain data just across the 2 time points, 3 months and 9 months. And the bottom panel is our other primary outcome of function across the 2 time points. And if you look, what the little box is showing is the mean between group difference with the 95% confidence intervals around those. In a non-inferiority trial, what we're looking for is that those confidence intervals do not cross that non-inferiority margin, which is the dotted line. So if they don't cross that dotted line, we can conclude that the new treatment, in this case, video consultations, are non-inferior to the comparator, which is in this case, in-person care. And so what you can see is that the confidence intervals are not crossing those dotted lines. And so we can conclude on these primary outcomes that video conferencing is non-inferior on both pain and function. With our secondary outcomes, we found that adverse events were minor and the typical sorts of adverse events we expect with exercise in osteoarthritis, and they were not different across the groups, lending support to, or refuting that argument that telehealth is risky or unsafe. Many of our secondary outcomes did not differ across the groups. And in fact, what we did find was that there were a range of secondary outcomes where video consults were actually superior to in-person care. And these included self-reported physical activity at 9 months. It was the participant rating of therapeutic alliance. So how they felt their rapport or their working relationship was with their clinician, consultation satisfaction, consultation attendance. So we found that people attended more consults via video conferencing than they did in person. We found that adherence to the strengthening program was greater in the video consults group. And not surprisingly, we found that the video, that distance travelled was far greater in the in-person group, 45 kilometres on average across the consults for those people attending in-person care. And so when we looked at the cost effectiveness analysis, we found that video consults were non-inferior to in-person care, also in terms of quality adjusted life years over 9 months. We found no difference in total costs between groups when we looked at the economic analysis from a health system perspective. And when we took a more societal perspective and considered individual private time and travel costs needed in getting to and from visits, we actually found that video consults offered cost savings. Perhaps the only finding that we found that could be considered negative towards video consults was that they increased the first consultation time on average by 2.6 minutes compared to in-person care. We carefully built into the trial a lot of strategies to try and minimise these tech issues, because that's something that often gets thrown up when people talk about telehealth. Oh, there's too many tech issues, it's too hard. We chose Zoom deliberately. Remember, again, this trial was designed pre-COVID, because when most people were unfamiliar with telehealth specific platforms, Zoom had some sort of familiarity to a number of people from a work or an employment-based reason. So that's why we chose Zoom. We had quite a dedicated, as I've talked about, the physio training program, and I'll talk in a little bit about the evaluation of that in a moment. But our training really focused on including training of the physios on how to troubleshoot common problems in the e-learning modules. And we were really pretty mean, I think, to our physios when they did that mock consult with Alex, one of our research members. He actually started that. We told them that you're going to go through a mock consultation with a physio just to check that, you know, you've got, adequate competency with video consults. But we got Alex to act like a patient having audio difficulties, and the physios didn't know that. So they had to, from the very get-go, once they connected with Alex, he had no audio and they had to work through that. So we really threw them in the deep end there, knowing how to do that. Participants were provided with really detailed booklet with step-by-step instructions on how to set up and use Zoom ahead of that first consult, and both parties were given a phone number so the physio could call the participant in case of issues. Nonetheless, we were interested in knowing what was the nature of the technical difficulties experienced in peak. And so we did an audit of the physio notes and the consult recordings from a subset of consultations. And we formed 3 subgroups: video consults where the physio had said there were some tech issues, video consults where they'd said there were no tech issues, and we also had audio recordings from some in-person consults. And then we took some samples and compared the duration of consult components across them to have a look at the nature of these tech issues and how they might have impacted different consultation components. And that's what this is showing. Tech issues were documented in 37% of the initial consults. But the types of problems were typically issues with audio or video. And you can see over here, this top bar shows how the time spent in the consultation was broken up across the different aspects. Assessment was the assessment procedures, giving the education. Orange was prescribing the strengthening exercise, red was doing the physical activity, and blue was the wrap up. So you can see that the technical issues really happened at the very beginning, and really didn't have any major dramatic impact on effective consultation time. So what we found was that when they did occur, they really only accounted for 3 to 4 minutes of the consult time, really at the beginning. And the physios were generally able to troubleshoot most of those quite easily. So what are the implications of the PEAK trial findings? Given that we've shown that physio video consults are non-inferior, we've shown that patient and physio concerns about therapeutic alliance, satisfaction and safety are not compromised like there's common misperceptions, and that the trial really does provide high quality evidence about the clinical effectiveness, cost effectiveness and safety. This is really important because we know that people with osteoarthritis, so consumers of physio services, really do have misperceptions about telehealth. This is some data collected by Belinda Lawford in her PhD pre-COVID, asking consumers, Australian adults with hip and knee OA, whether they think that telehealth would be effective, affordable, useful and safe. And it's broken up to, the black bar represents telephone delivered care and the grey video over the internet. The moral of this data here is that really about 25% or more of patients had concerns or did not agree that telehealth would be safe or effective or acceptable to them. So we really do need to be able to educate consumers. We need data from clinical trials such as PEAK to really start countering these misperceptions. We asked our PEAK participants how they felt after being allocated to video consults, or a subset of them. Sorry, because this study we nested into the trial once we began. Because remember, people signed up not knowing they were signing up for that they could potentially be getting video consults. And what we found was that we asked them to say, in one word, tell us how you felt when we told you you were going to be getting video consults. And you can see here that people really broke up into three groups. The largest group, about half of them, were what we would call positive. They were, these word clouds give you an idea of the sorts of words and feelings they told us. They were happy, comfortable, relieved, relaxed, interested. But there was a substantial subgroup of what we called negative emotions: disappointed, apprehensive, nervous, anxious, silly, stressed, reluctant. And a much smaller neutral group who really didn't fall into those categories. So what this negative subgroup, we asked them, why did you feel that way? Because I don't think it will be effective, because the physio can't see or touch me, because I think in person will be better, I can't communicate effectively, and I'm not good with technology. One of the really interesting things was that when we came back to these people after they'd had their treatment, their experience, their video consults, we found that actual experience, even though they didn't sign up for telehealth, they went in feeling that way, disappointed and apprehensive, that perceptions can change. We found that 61% of these people actually found video consults exceeded their expectations, and half of them were moderately or extremely willing to use telehealth again in the future. However, it is important to recognise that there was still a proportion, about a quarter of those people, who were not willing to use telehealth in the future. So there is a subset of people who are resistant to telehealth. They prefer hands-on. They believe it doesn't allow adequate assessment or observation, and they just prefer in-person, or they simply just don't like it. So I think we as clinicians need to be thinking about how we might be screening our patients for preferences, thinking about hybrid models of care, and also setting appropriate expectations about tele-rehab. And so I've just put some examples of the text here that we used in setting expectations in PEAK. Your physio will not be providing massage or other hands-on treatments, because research shows that these are not really effective in osteoarthritis, and that exercise and physical activity are more important. So we really need to be taking a much more proactive approach in educating patients about the pros and cons of telehealth. Now, there's also implications of PEAK for delivery, funding and training of physios in setting up telehealth services and delivering care. And we know also from Belinda Lawford's PhD work, where I showed you the data from the consumers a few slides ago, she also collected data from Australian physios about how they felt with using telehealth for delivering care pre-COVID again. And again, you can see up to a quarter, more than a quarter, did not agree that telehealth would be effective, useful or safe. And certainly a survey that we did on Australian physio COVID experiences with video consults showed that even though people were thrown into telehealth during COVID, most had no prior telehealth training, and only about 1 in 5 had provided video conferencing prior to the pandemic. And that's reflective of data that was collected in an international survey as well, more broadly in allied health, that also highlighted that the lack of knowledge, skills, resources and confidence are really a major barrier to physios wanting to offer or implement telehealth services. Now that we know that telehealth funding came about for telehealth for the first time in COVID, first as temporary measures, and now most of these temporary measures have been made permanent, we're seeing third-party payers now subsidising telehealth visits. Telehealth is here to stay, and there's a recognition about that. And certainly most physios in our COVID survey said they intended to continue offering telehealth. And so we really need to think about how we're going about training physios, ideally the emerging workforce. And this is some work from another PhD student of ours, Luke Davies, who was looking and did a qualitative study with physiotherapy educators at Australian universities to explore to what extent telehealth training is being incorporated into curricula. And what we found was that it really varies substantially to next to nothing, to some places have more, some might get a mention in university lectures, some might get exposure in clinical settings. But a really dominant theme was that there's real challenges in finding space in curriculum. our curricula are jam-packed already, and trying to fit telehealth in there is going to be a challenge. And so we really need to think about scalable ways that we can deliver telehealth training to the not just the emerging physio workforce, but to all the, you know, the 30,000, more than 30,000 registered physios we have around the country. And so that we evaluated the training we used in Peak with a qualitative study in our Peak physios. And what we found was that they all really talked about their inexperience with telehealth at the beginning, but they really found that the e-learning modules helped build that knowledge, and then that practice and experience of actually using and engaging in telehealth was really what helped also build confidence further, so that then they were able to really implement and deliver care. And these are just a few quotes to give you an example. One thing that they really valued was the e-learning aspect, was that rather than attending PD in person, people felt that they thought they might be, you know, technologically competent before, but the e-learning modules really gave a well thought out approach to telehealth. And the final quote there was that when COVID rolled around, that our physios felt really well prepared. And in fact, it was our physios in the Peak trial that helped us then consider launching our e-learning modules that we developed really in-house for the RCT on a wider scale to help during the COVID pandemic. And that's what we did. And then we evaluated that once we launched that live. This is just an evaluation of people who registered for over between April and November in 2020. And you can see how we had people from 97 countries sign up to do those modules, and really snowballed through word of mouth and through work colleagues. And when we looked at, we asked people before they completed the e-learning modules, how confident are you to use video conferencing with your NeoA patients? And what we found that this is showing the proportion of people who rated their confidence from 1 to 10, where 1 is not at all confident and 10 is really confident, that only 13% scored 8 or above. So generally people had low confidence. After training, we can see a real shift in that confidence level. So even completing these e-learning modules, but without the practice, really helped boost confidence. And we found that with follow-up survey 4 months later, that people really had found that that training program had influenced or informed their clinical practice, with people saying that they'd used what they'd learnt in their, not just in their telehealth consultations, but in their in-person consultations. They'd use the information booklets that we provide within the training program to download, and the other resources, the video library that we provide of exercises to support telehealth. All sorts of different things people had implemented in their different clinical settings. And so that inspired us to release or redevelop the course, taking it off the university LMS, which was really clunky for people to access outside of the university. And now the course is available through FutureLearn, who are a provider of e-learning courses, and people can access this for free for 4 weeks, or have, if you want more time, unlimited access, you can access that for a small fee. And since then, we've had collaborators around the world translate the course into Spanish, Portuguese, and Chinese, because of the real lack of telehealth training that's everywhere. So in summary, we've shown with Peak that video consults are non-inferior to in-person physio care for NeoA. We now know that, you know, funding and telehealth services are here to stay. And so now we really need to think about how we can use the evidence from trials such as this and the nested work that we did to really help refine, improve, and really enable more telehealth services. But there are implementation challenges that remain, with physio resistance to taking on new service delivery modes. It's not just patients who think that physio is a hands-on profession. Physios seem to, a lot of physio professional identity is tied up in manual therapy and hands-on treatments. And so I think that feeds in to some of that resistance. We've got work to do around upskilling and training physios in telehealth. and work to do in educating consumers, really, and opening their minds to the scope of physio practice, and that physio is more than just hands-on. I'd like to finish by acknowledging my co-authors on the RCT that you can see named there, and as I said, a particular shout out to Penny Campbell, who really did a sterling job in managing the trial, and Alex Kimp, who really was integral in doing so much work in training the physios and setting up all of the technology that we needed for that. Also, a special shout out to the 15 physios who, you know, worked hard and worked with us over a number of years with this trial and through the challenges of COVID. When we'd say it's on, it's off, we're recruiting, it's not, you can stop seeing your in-person patients, start again, really sticking with us. So, and acknowledging the NHMRC who funded the trial. And I'm just going to finish there by putting a plug there to our Centre for Health, Exercise and Sports Medicine website, which really has got lots of useful information in there about our research, but in particular, the outputs of our research, which we try really hard to turn into useful patient and clinician resources and make them freely available. So you can find all sorts of stuff in that website, including signing up for our Knowledge Translation Network if you're interested in being part of receiving newsletters about what we're doing, sharing our research findings, and often calls out to participate in research as well. So I am going to stop there, and I think we're going to go to Tor.
Fantastic. Thanks very much, Rana, for an amazing presentation. We have got 15 or so minutes for questions. So I'd like to invite anybody who has a question for Rana to post a question in the Q&A function, and you should see if you move your mouse over the screen, you should see the Q&A option at the bottom of your screen. But we do have one question already. So this question was posted by Ingalisa, and Ingalisa says, "Thank you for an excellent presentation, Rana. I'm based in the Northern Territory and we didn't have much lockdown during COVID. It could have been a great addition to your study." But her question is, what were the exercise regimes for both of the groups in the PEAK study?
It's a good question. So the strengthening, I would call it a semi-protocolized exercise regime. So focused on strengthening exercise, firstly, of the lower limb muscles. And we had a whole range of, probably around 30 to 40 exercises that span quadriceps strengthening exercises, hip muscle strengthening exercises, calf muscle, some balance exercises. The physios were allowed to choose from that whole range of exercises a set of 5 or 6. So exercises that would best fit their patient needs and goals. But they had to choose a couple of quads, a hip exercise, but there were a few little rules and regulations around it, but largely it was very individualized, and patient and the physio could change the exercises at subsequent consultations as well. And a really important component of the strength program was what happened in the 5th consultation, which happened towards the end of the 3 months, but we wanted patients to carry on with doing their exercise over time and not get stale. So the physios also educated patients with how they could choose and change their exercise program from those exercises within the booklet. And if you go to our website, or if you signed up to do the PEAK e-learning program, you can download the exercise booklet and get links to the whole exercise library as well. So we've got pretty much all of that on our website and within the e-learning program. And so just to clarify, the exercise choices were identical, whether it was in person or in video consults. So just because someone was seeing someone in person, they weren't allowed to start prescribing different exercises that were outside what was within that booklet of choice.
Thanks, Rana. There's a couple of questions popping in now. So the first question asks about the 15% attrition rate of the patients and which groups they were from. But I know, just to clarify that the 15% attrition was factored into the power It's a sample size calculation. It wasn't the real attrition value. So the sample size was set to allow for up to 15% attrition. So the actual attrition rate was quite small, wasn't it? It was like
it was really
97,
small,
yeah,
and
3%.
I'm going to,
yeah.
yep, as you flick back, I can go, because I know I flicked through that slide quite quickly.
That's great. And the
Once I
question is
get,
actually about whether the attrition was the same in both groups. So do you have any idea about the sort of randomness of the attrition?
what you
that we
can
did
see,
find?
yeah, look, it's fairly similar. I think what I've brought up now is the trial flow chart. And so to answer, can you see my arrow on the screen? No, you probably
The
can't.
arrow, the text is very
Yes,
small.
yeah, it is small, and I'm sorry about that. But if you look down, what you can see is that at the 3-month assessment, we had lost 3 people from the telehealth arm at the 3-month assessment, compared to 8 at the in-person care arm. So we did lose a few more in the in-person arm. At the 9-month mark, we'd lost 6 people out of the telehealth arm versus 9 in the in-person arm. So yeah, a few more had dropped out of the in-person arm, but probably not much to really write home about there.
And just to highlight the point that you've already made, is that that's actually a very low attrition rate for this type of
Yes.
study as well. So congratulations to the team for
Yeah.
that.
Yeah, we would have been happy with 15%, but yeah, it was effectively 3% at the 3-month mark.
We've got another question from Evangelos. Now, Evangelos says, congratulations, Rana and team, fantastic study. What tools did you use to collect outcomes such as range of motion, strength, and those types? And they're particularly obviously interested in how it was done for the online group, but I'm sure it was the same for both groups.
We didn't collect range of motion or strength in this trial. For trials of osteoarthritis, the core recommended outcomes, the most important outcomes that matter to patients and are recommended by internationally and global bodies for clinical trials, are pain and physical function. And so really taking that patient-centered approach. So we used, all of our outcomes were self-reported by patients using REDCap. So we used electronic data capture where patients reported those survey, answered most of their survey, with the exception of stuff like collecting data on travel distance that was recorded in logbooks. The only secondary outcome that was measured by the physiotherapists was consultation time, that physios recorded that in their treatment notes. So in terms of strength and range of motion, we didn't measure those, so we can't draw any conclusions about how telehealth fares with those domains.
Great. There's some good questions still to go. I might just see if Jess, I know you had a burning question and I don't want to miss you out. Did you have a question you wanted to jump in and ask at this point?
Yeah, thanks, Tor, and thanks so much, Rana. That was fabulous. I guess my question was about, you mentioned the need to upskill future physiotherapists, and I guess my question was, how would it be the training program that you offer? Would that be relevant or appropriate for
Absolutely
ready to graduate level? Brilliant.
Yep, absolutely. We that there is no requirement. In fact, we've had people with osteoarthritis complete that course. There's no anyone can go into the Future Learn website, sign up and register. As I said, for the free registration, you get access for 4 weeks. So there's absolutely no reason why that could not be encouraged, disseminated, incorporated, even if it was, not a mandatory learning aspect for students in curriculum, but being provided as a potential resource for them. So it's totally appropriate. And I guess a lot of the flavour of the discussion tonight has been on the telehealth aspect. But the other important aspect that is in that e-learning course is there's a whole module on osteoarthritis. And so the upskilling that comes in that e-learning course is around osteoarthritis. It's around the use of principles of telehealth. And then one module is about the actual details of, well, how do I do this treatment in 5 consultations with people? How How do I teach them? How do I pick these exercises? So all of that is in there, and yes, very appropriate for students. And we've had people who are not physios, other health professionals also sign up for the course. So there's a lot of a lot of benefits in there for other health professions as well.
Oh, brilliant. Thanks, Rana. I'll be sure to flag it with our final year physios. And I think you made an interesting point about that identity piece. And I think potentially introducing it early on would help sort of that polarization with technology integration as part of physio identity. So that's wonderful.
Absolutely.
Thank you.
The next question I'm going to pass on to you, Rana, is from Bernadine, and she says, "Thank you for this excellent presentation. I was wondering if those in the telehealth arm, if any caregiver or significant other were involved and required to be present, such as setting up the Zoom session." And before I let you answer, I'm just going to pipe in there and say I was involved in a meta-review and meta-analysis looking at telehealth for people for rehabilitation in neurological conditions for prevention of falls. And in that situation, that was definitely something that had to be considered in the setup of the studies, is having somebody there as a caregiver to help, particularly because we were doing some balance training. Oh, not we, but the studies that we looked at were doing some balance training as part of their intervention. So it is quite interesting when you look at sort of the spectrum of physiotherapy interventions that could be delivered over telehealth. But I'll let you answer the question.
Yeah, no, it's a really good question. Thanks for that. My answer is, I'm a researcher and I would like to rely on data. We didn't actually collect data about who had people there, but I can tell you there was certainly no requirement from a safety aspect with the nature of the tasks and interactions that were being done between that would require a second person there to stop someone from falling, for example, thinking of the example that Tor just said. However, anecdotally, I would definitely say that people probably did use another significant other, possibly their daughter or their son or their grandchild, in the setting up and navigating potentially that the instructions we gave them, which we'd work through and put screenshots, but to help them with downloading Zoom or doing that aspect. So yes, there would have been, I believe, some assistance there. I do want to point out though that we also do know that in the other arm, in the in-person arm, there was also a need for significant others, because there was a proportion of people, and I can't remember the number, who required someone to drive them or to get them physically to or from their in-person consultations. So although there might be a bit of a load on the telehealth side from helping with the tech setup, we can't forget that significant others are also often the ones who are driving people with osteoarthritis around to and from their appointments as well.
And getting back to the exercise program that was delivered as part of the PEAK trial, there's another question here about the strengthening exercises, and did they involve the use of TheraBands, weights, or any other equipment?
Yeah, we designed the program to be able to be done at home with only it was either with body weight. Probably at least half of the exercises in the booklet utilize body weight for resistance, or they were exercises that could be done with TheraBand, and we provided the patients with a couple of different colors of TheraBand so that they could change the resistance. So no, it was designed so that people didn't have to go out and buy cuff weights or navigate that. So the program was all around trying to keep it as simple, self-directed and unsupervised in the home as possible, so to maximize implementation. And that's really the approach that we take in most of our clinical trials in Chesham. In fact, I can't think of anything. There's not many trials that we're doing these days where we're using cuff weights. We are usually using the principles of what can be done at home, using body weight and simple, cheap equipment if we have to have it, which is what we would consider TheraBand.
We've got time for just one last quick question, Rana. So this question from George. I'm not sure I completely understand the question, but I think that what he's getting at is that what was the relative uptake of participants into the study in metropolitan versus rural areas?
Good question. Great question. And I'm trying to remember the data, but I think it was roughly around, we had a good chunk, possibly 30-ish% that were outside metropolitan areas. It could be more, and I should have that data. But we deliberately, because we had physios that were located, and you'll have to remember our physios came from metropolitan, inner and outer regional areas, if we think about the way the government, you know, uses postcodes to categorize that. And so patients needed to be, we had to recruit in areas around those physios, because it was no point us recruiting people in a far remote area and then they got randomized to a physio who might still be hundreds of kilometers away. So, but yes, it was, we were pretty happy. It could have even been about 40% that were outside metropolitan areas. And so they largely spanned inner and outer regional areas, as opposed to those sort of remote, very remote classifications.
That was a bit of a constraint by the nature of the being in a randomised controlled trial.
Absolutely, yeah.
All right, so we are going to end the webinar now. I'd just like to quickly thank once again Professor Rana Himmen for a fantastic presentation, and thank all of our attendees for participating and attending the session. Hopefully you'll be able to join us for our next webinar as part of our 30 Years of Physiotherapy at University of Melbourne celebration. And so I'll say goodbye from all of us to all of you, and best wishes. Goodbye.
And just want to say, lots of applause there, Rana, if you can't see from the bottom of your screen, floating up. So congratulations.
Thanks very much, everybody.